Thank you so much, Dr. Lang. Let me just pull up my screen. I hope that's sharing okay. Good afternoon, everyone. I'm very excited to be here today and to speak about the MD Anderson approach to glioblastoma imaging. We only have about 20 minutes, so this will be a rather high-level overview with some cases to keep everybody awake, I hope. No disclosures. So the purpose of this talk will be to touch on the role of imaging in glioblastoma care. I will present the MD Anderson Advanced Brain Tumor Imaging Program and illustrate how we use this with some case examples. And finally, I will point to some future directions for CNS imaging. So as we all know, glioblastoma is the most common adult primary brain neoplasm. It has an abysmal prognosis, and although progress has been made in the molecular classification, and thank you, Dr. Fuller, that was an excellent talk, we continue to show little progress in moving the needle on overall survival. Imaging has a critical role in the care of glioblastoma patients from the time of presentation and throughout their clinical journey. MR is by far the tool of choice for imaging of the CNS. And at the time of presentation, it is used to diagnose glioblastoma and differentiate it from other etiologies, such as, for example, metastatic disease. The initial MRI is also crucial for pre-surgical planning. And I'm not going to go into it too much today, but one of the things that we do quite regularly at our institution is functional MRI for better surgical planning. The majority of patients will undergo some form of surgical resection, ranging from a stereotactic biopsy through a grossal resection. Timely post-operative imaging within the first 48 hours gives the most accurate representation of the extent of surgery and has implications for prognosis and aids in radiation planning. Surveillance imaging during and after treatment is used to evaluate treatment response and for the evidence of progression. This is the greatest challenge. The greatest challenge in this post-treatment period is to correctly distinguish between progressive disease, pseudoprogression, and pseudo-response. A major obstacle to developing and assessing a treatment regimen, which clinicians often come up against, is an ability to accurately measure treatment response. Radiographic response rate often act as surrogates for treatment response and are used to determine treatment and clinical trial selection. The radiology community has tried to tackle this issue by developing standardized ways of measuring radiographic response. First with the McDonald criteria, and later with RANO and modified RANO and different permutations thereof. As we all know, these systems are flawed, even as they try to incorporate ways to measure non-enhancing tumor or account for pseudoprogression. So a quick overview of glioma imaging, just for those who are not looking at images on a daily basis. As you know, gliomas are expansile volume positive tumors. They are T2 hyperintense and infiltrative. Tumor extent can be difficult to distinguish from surrounding edema, particularly in the post-treatment setting. With edema, you can look for sparing of the cortex, while infiltrative tumor will typically invade the cortical ribbon and with involvement of the pia. Gliomas can present with hemorrhage in rare instances, and areas of intermediate T2 signal and diffusion restriction may denote higher cellularity. Presence of T2 hyperintensity that suppress some flare, or the finding of the T2 flare mismatch sign, which Dr. Fuller showed, is again, like he said, almost 100% indicative of an IDH mutation. Contrast enhancement is due to microvascular proliferation, and the new vessels that form have a poor blood-brain barrier, resulting in leakage of contrast. This typically denotes a higher grade tumor. The typical glioblastoma will present as a mass with central necrosis surrounding monodular enhancement and varying degrees of edema and infiltrated T2 hyperintense tumor. On MR spectroscopy, you will see reversal of the Hunter's angle with elevation of choline, with inversion of the choline to creatinine ratio, and decrease in NAA. And lipid lactate peak may also be present. And high-grade tumors will be FDG avid, and you will see abnormal perfusion on all perfusion parameters. So what is pseudoprogression? It's a subacute radiation-related phenomenon. What happens within about 3 to 4 months after completing radiotherapy and as a result of a transient increase in permeability of tumor vasculature, resulting in increased enhancement within the radiation field that resolves spontaneously. It is increased in MGMT methylated patients by a factor of about 2. It is estimated that about 30% of patients undergoing the first post-radiation MRI will show increased contrast enhancement that will eventually subside without any change in their treatment regimen. It is critical to correctly identify pseudoprogression to prevent premature discontinuation of effective adjuvant therapy. Reno addresses this phenomenon by saying that progressive disease can only be diagnosed in the first 12 weeks after radiation if the majority of the new enhancement is outside the radiation field. So here's an example case. This patient underwent subtotal resection of a left temporal tumor with increasing enhancement at the resection site, both following radiation and then again after one cycle of Temidar, all within the radiation field and within 12 weeks of radiation. This enhancement spontaneously improved and can therefore be classified as pseudoprogression. On the other hand, patients may have imaging findings of pseudo-response. This occurs typically in patients that are treated with anti-angiogenic agents and may produce a marked decrease in contrast enhancement. The prototypical agent is, of course, Avastin, a VEGFR inhibitor, and this may reflect improved or normalized overall vascular permeability rather than the true anti-neoplastic effect. It may occur as early as 1 to 2 days after starting treatment with Avastin and can result in high radiologic response rates of about 25 to 60%. For this reason, Reno classifies a response as improved enhancement while being treated with anti-angiogenic agents that is sustained for 4 weeks. Here is a patient who had undergone resection, chemoradiation, and adjuvant Temidar and was found to have increasing pericavitary enhancement on the left. He was started on Avastin, and as expected, there was significant improvement of the enhancement along the left resection cavity. Now, if I can draw your attention to the contralateral right side, to the arrow, while the enhancement was improving, there was progression of non-enhancing tumor in the right frontal lobe, contralateral to the site of prior resection, that eventually started to enhance. This was an example of pseudo-response. Beyond the first 3 months after radiation, patients can present with findings of radiation-related injury or radiation necrosis. This can be months to years from the time of radiation and truly is the biggest challenge for clinicians and radiologists in the post-treatment setting. Unfortunately, the conventional MRI imaging appearance of radiation necrosis greatly overlaps with true progression. Furthermore, radiation necrosis and tumor progression frequently occur together. As radiologists, we'd like to think we can distinguish the two. Unfortunately, studies have shown that no single conventional imaging MR parameter has been proved to be specific. At MD Anderson, we have developed an advanced brain tumor imaging protocol to tackle this issue and address the questions and to be more specific when we try to distinguish radiation necrosis from progression. Our advanced imaging program, or ABTI, consists of MR and FDG components. Each exam is tailored to best assess the findings in each patient, with trainees and faculty reviewing the imaging and clinical history of the patient to make sure that we can do the best we can for that specific clinical scenario. It also requires highly skilled technologists that can perform advanced MR techniques and PET. We rely on our imaging physics friends to help us process some of the data. In addition to our conventional MRI, we add perfusion. This includes dynamic contrast enhancement, dynamic susceptibility contrast, and arterial spin labeling. We also routinely perform MR spectroscopy, taking great care to place the voxel, whether it's single or multivoxel. PET imaging, which is FDG PET, consists of a standard 1-hour FDG PET image acquisition followed by a delayed 5-hour image acquisition time point. So why do all of this? This is a study looking at multiparametric MR imaging, including perfusion and spectroscopy, and how well it can distinguish recurrence. As you can see, each individual perfusion parameter has an accuracy of about 60%, as noted at the top of the table. When they combined 2 perfusion parameters, the accuracy increased to around 70 to 80%. Now, if you combine all 3 perfusion parameters or techniques, they give an accuracy of about 83%. And by adding MR spectroscopy, this further goes up to 90%. There are some limitations to this. It is a lengthy study, and you need a cooperative patient, and the study may be degraded by movement. ABTI is most helpful in high-grade tumors and are not really very specific for findings in lower-grade gliomas. Lots of confounding variables in the cases of immunotherapy, which is becoming more commonplace and is a real challenge that we're facing. In the acute post-treatment phase within 6 months of radiation, there is a higher incidence of false positives due to the ongoing changes from radiation injury. If the lesion is small, it may be below imaging resolution, and if it's located in a challenging location near the skull base or vertex, several of the imaging parameters may fail. So I mentioned FDG PET as part of our ABTI program, or Advanced Brain Tumor Imaging Program. But isn't FDG PET terrible for CNS tumors? So as we all know, the brain runs on glucose, resulting in a high background tracer activity on FDG of the brain parenchyma, particularly of the cortex and basal ganglia. This can mask tumor uptake. Standard imaging with FDG has an acquisition time point at about 60 minutes after tracer injection. Studies have shown that gliomas will continue to increase in FDG avidity beyond the 60-minute standard time point, while normal brain parenchyma will decrease in FDG avidity. This causes an improvement in lesion to background ratio on delayed imaging, increasing lesion conspicuity. It is also known that change in FDG avidity is associated with tumor grade, with a greater than 20% increase in activity at 5 hours after tracer injection associated with high-grade glioma. This information has been proven successful in differentiating radiation necrosis from recurrence, with a change of greater than 0.2 of lesion to background ratio, highly sensitive and specific for distinguishing radiation necrosis versus viable tumor. At MD Anderson, we have operationalized this model and incorporated it into our ABTI, or Advanced Brain Tumor Imaging Program, and have done more than 200 cases of delayed PET with great results. Now let's turn to a few cases. I hope nobody has fallen asleep yet. So this is a patient that presented with a glioblastoma. This was after resection and chemoradiation, and the patient had non-specific nodular enhancement along a right parietal resection cavity with surrounding to T2 signal abnormality and mild mass effect upon the right lateral ventricle. The clinical question, as always, was to differentiate between radiation necrosis and recurrence. An ABTI was performed, and as you can see, there was no significant increase in permeability on the DCE. There was no significant increase in cerebral blood flow in the ASL, or arterial spin labeling, and there was mild increase in relative cerebral blood volume. Looking at the spectroscopy, there was inversion of the choline to creatinine ratio, and Hunter's angle was inverted. As you can see, I've labeled this as negative. So why did I consider this a negative study, not indicative of recurrence? The answer is in the contralateral normal brain spectrum. There was no elevation of choline in the region of interest relative to normal brain parenchyma. So this was findings were most consistent with radiation necrosis. Findings of radiation necrosis were then confirmed on delayed time point PET. PET imaging demonstrated diffuse decrease in activity in the right parietal lobe with no focal worrisome activity seen. Next case. This is a right temporal glioblastoma, also status post resection and chemoradiation. Again, we see this nonspecific enhancement in the right temporal lobe noted on imaging. Is this radiation necrosis or is it true progression? In this case, the lesion was located near the skull base, which makes MR spectroscopy and DSC challenging. A PET MR with advanced brain tumor imaging was performed. Elevation of the cerebral blood flow was seen on ASL imaging, but with only minimal increase in permeability on dynamic contrasting enhancement. Fortunately, we had also had the ability to do a PET in this case, showing mild increase on the initial time point, but with significant increase at the 5-hour time point with increasing lesion to background ratio. This was consistent with a high-grade tumor recurrence. And finally, this is a patient with glioblastoma. also status post resection and chemoradiation. And this is another case where the lesion location was challenging near the vertex. Additionally, the patient was on Avastin. So is this recurrence or radiation necrosis? As expected, due to the location, our spectroscopy failed, and I'm just showing it here in the lower corner so you can believe me. Only mild increase in permeability was seen on DCE. There was no increase in relative cerebral blood volume on DSC, and there was some focal increase in cerebral blood flow on ASL. But these findings, it was hard to say whether this was truly recurrence or just radiation-related change. Delayed time point PET imaging demonstrated significant FDG avidity of this lesion in keeping with tumor recurrence. This case illustrates how anti-angiogenic agents such as Avastin can give false negative results on perfusion imaging. This is another GBM patient with nodular and somewhat shaggy enhancement in the right hemisphere. The parietal component seemed to have some increase in perfusion parameters both on DSC and DCE. But the FDG avidity, if you look at the right-hand corner, was predominant in the right frontal lobe. The MRS or the MR spectroscopy also suggested tumor in the right frontal lobe with a reversal of Hunter's angle. So this was a very confusing case with mixed findings, both on perfusion and on PET as well as on MR spectroscopy. So what was going on here? This was a patient that was receiving immunotherapy. And despite using all of our best imaging tools, MR and PET, we could not distinguish treatment-related change versus true progression in this patient. There is a definitive room for improvement, and a silver bullet that would be correct 100% of the time has yet to be found. The use of amino acid PET imaging has demonstrated significant promise in brain tumor imaging. Amino acid PET imaging has been shown to be more accurate in identifying infiltrated regions of tumor, extending beyond the areas of contrast enhancement, and better distinguishing tumor versus non-tumoral edema and normal brain. In addition, amino acid PET provides a functional and metabolic information about the tumor and may identify tumor regions with different biological and clinical behavior. In patients with grade 3 or 4 gliomas, amino acid PET complements conventional MRI by providing additional information about tumor extent and biology. So why aren't we using this more routinely in the US? Unfortunately, in the US, only fluciclovine, which is an F18 analog as well, is FDA approved for prostate cancer. And at this time, it's difficult to use any of these tracers clinically due to problems with reimbursements. So we need more studies, more cases to prove to the FDA that we should include brain tumors as part of the indications to use these new analogs. At our institution, we have a study currently ongoing looking at glioblastoma volume and radiation response using F18 fluciclovine. We hypothesize that imaging with F18 fluciclovine will be superior to anatomic MR imaging in glioblastoma tumor volume assessment and at various stages of their treatment, and that F18 fluciclovine defined tumor volumes will improve, but may not resolve with surgery and radiation. This is just an imaging example in a patient that happened to have an FDG PET previously. And as you can see, there is some increased uptake in this tumor, but it's far more conspicuous on the fluciclovine study, where the background brain uptake is essentially zero. So in summary, imaging findings, imaging is a critical component of patient care in the GBM population. Multiparametric MR and or PET imaging is essential to increase specificity of the imaging findings in complex post-treatment cases. And we do have promising research of new amino acid PET tracers and their use in CNS tumors. And I want to thank some of my team members who have helped me with this presentation and some of this work. And thank you so much, everyone, for your attention. And I'll end with a picture of the Northern Lights, as I'm originally from Norway. Thank you, everyone.